All right, so today we're really going to focus this talk on special considerations in certain populations of people who are either at risk or infected with Hep B or had prior exposure. So let's get started. So this is our 28-year-old patient. This time she's pregnant. She's 32 weeks. She was born in the United States. As you'll recall, her parents immigrated from Taiwan 2 years before she was born here. She was screened for hepatitis B as part of routine prenatal screening here. Her test results show that she's surface antigen and core antibody positive to hepatitis B. Additional serologies show that she's E antigen positive, and her Hep B viral load measured by the DNA PCR is 1.1 million IUs per ml, and her ALT test is 18. So the question is, to keep in the back of our mind, is what do we do next? So we're going to return to this case towards the end to have some discussion. So let's start by talking about hepatitis B and pregnancy. So we know that during pregnancy, the immune system is modified to tolerate the fetus and prevent fetal rejection. Immune priming is known to occur mostly via macrophage activation of CD4 and CD8 T cells, not really via B cell mechanism. CXCL3 expression in liver macrophages is ineffective at birth and becomes competent as one becomes older. And this could be the potential mechanism by which there's inverse relation observed with age-dependent clearance or persistence of Hep B. So we talked about the age at which you are exposed or infected to Hep B really determines your risk of chronic infection, such that really the simplest way to explain this is that your immune system at birth is not in a very good place to try to deal with this virus and get rid of it. And so therefore, if you acquire it as a newborn or at the time of pregnancy or birth, your rate of developing chronic infection is much higher compared to adults who acquire this infection. So, really mother-to-child transmission occurs via, germ cells, transplacental, or what we call intrauterine, and perinatal at the time of delivery. And perinatal transmission is what accounts for the vast majority of mother-to-child transmission. So it's, really been widely accepted by U.S. Preventative Services Task Force and other agencies to really make sure that we screen for hepatitis B as early as possible when you're interfacing with pregnant women. So it's really recommended that every pregnant woman gets screened for hepatitis B with, at a minimum, the surface antigen test. And in those who actually are found to be surface antigen positive, it's important to assess liver function very early, as early as possible, particularly to try to get an assessment of whether or not this person has advanced fibrosis. And this can be done using a combination of blood work, an ultrasound, and some non-invasive markers of fibrosis. Just a little caveat, I think in some of the past sessions, we've talked briefly about the use of FibroScan, and FibroScan is not FDA approved for use in pregnant women. And it's mostly based on a lack of studies, and therefore typically do not perform that in women who are pregnant. And so what is recommended is to check the ALT, the Hep B E antigen, and the Hep B DNA close to the third trimester or during the third trimester to really determine the need for antiviral therapy, which we're going to talk in a little bit more detail. And then it's really important to monitor patients up to 6 months postpartum by following the ALT and the Hep B DNA level to watch for particularly flares during the postpartum period, which can happen quite commonly. Now, the risk of mother-to-child transmission with prenatal procedures is pretty unclear. Some of the earlier studies seem to suggest that there was an increased risk. Some of the more recent studies have shown that the risk might be overstated or not very present. So 50% risk of mother-to-child transmission rate in mothers with amniocentesis performed are really found in mothers who have a very high viral load. So when the Hep B DNA is above, 7 log copies per ml. Invasive procedures should be performed, the ASLD and others recommend when medically indicated. However, women with very high viral loads are recommended to be counseled and informed of potential increased Hep B transmission risk with invasive procedures. And the data regarding C-section versus normal spontaneous vaginal delivery are conflicting when we're talking about risk of mother-to-child transmission of Hep B. Hep B infection, it is recommended based on the studies that are available for review that should not be really the primary decision driver in terms of determining the mode of delivery. And that really should be, determined based on the obstetric indications. We do know that Hep B DNA is found in up to over 50% of vaginal secretions. But again, this benefit of doing a C-section over a vaginal delivery has not been very well established, and therefore we don't say that, Hep B infected moms are recommended for C-section. All right, so there are ways for us to offer prophylaxis to try to reduce the rate of mother-to-child transmission. And these really hinge around interventions we can do for the newborn. So the two hallmark features of this immunoprophylaxis include, number one, administration of hepatitis B immunoglobulin, plus number two, Hep B vaccine. And this is recommended to both be done less than 12 hours after birth because this offers the greatest chance of protection in up to 85 to 95% of infants. Additional doses of both hepatitis B immunoglobulin and vaccine can be administered, particularly the vaccine, in months 1 and 6 in order to get the lifelong immunity to hepatitis B. So that's just following kind of standard vaccination schedules that we offer to people who are starting vaccine series for Hep B. Now, the risk of mother-to-child transmission is largely influenced based on the mother's E antigen status. And we know that mothers who are E antigen positive, who, also by way of being E antigen positive, are at higher risk to have higher Hep B viral load, have increased risk with mother-to-child transmission in the absence of vaccination or the absence of vaccination plus immunoglobulin administration. And this is, very different from E antigen negative women, in which the risk is much less. But with administering prophylaxis, you can have substantial reduction, in the E antigen positive mother scenario, from 90% risk of, mother-to-child transmission leading to chronic Hep B infection in the newborn, to 10 to 15% risk of chronic hepatitis B infection if you implement the immunoprophylaxis procedures that are recommended. And in E antigen negative women, that risk, while it's much lower without administering anything, is less than 5%. You can reduce it further to less than 1% in terms of risk of chronic infection with hepatitis B in that newborn. So we do know that the higher your hepatitis B viral load, the increased risk of mother-to-child transmission. And in studies, they've found that once the Hep B DNA PCR is in the 8 log copies per ml range, the transmission rates are as high as 9 to 15%. And this is also to just kind of mention that in lower viral loads, we still believe the transmission rate is somewhere between 3 and 7% based on the studies that have been done. But this is, as you can see, lower than women who have much higher Hep B DNA viral loads. The treatments, the antiviral treatments that we recommend for women who are pregnant, include lamivudine, talbivudine, and tenofovir. You'll note that TAP is not listed, and this is because of the lack of safety data available to recommend it as a first-line agent for women who are pregnant. And one note here is that tenofovir is preferred to minimize the risk of emergence of viral resistance during treatment. So really, while all three of these medicines are considered safe, tenofovir is really considered the drug of choice by AASLD and other organizations who have looked at the data. So tenofovir is preferred certainly in mothers. Any mom who has a Hep B DNA greater than or equal to 200,000 IUs per ml. And it is effective even if resistance to lamivudine and talbivudine exists. Fetal exposure to drugs during the first trimester can theoretically cause mitochondrial toxicity and potential risk for fetal organogenesis. And therefore, the ideal timing for initiation of antiviral treatment is between gestational weeks 30 and 32. And mothers with cirrhosis should initiate antiviral therapy as soon as possible during the pregnancy. So this is the one caveat to the recommendation to initiate therapy at 30 to 32 weeks, so that if you have a cirrhotic pregnant woman, you want to start therapy as soon as possible. And this is to avoid flares that can happen quite commonly during pregnancy, but don't have clinical consequences in somebody who's non-cirrhotic. And in cirrhotics, these flares can lead to decompensation and poor maternal fetal outcomes. So both the mom and baby are higher risk in that scenario. And so what do we do after the baby has been delivered? In that postpartum period, we see a lot of rapid hormone-driven immunological changes, and this is the main driver for these flares. Flares can manifest as asymptomatic and symptomatic, with pretty significant liver test elevations accompanied by a rise in the Hep B DNA. It's important to note that breastfeeding does not increase the risk of hepatitis B transmission, so there is no recommendation to withhold or not allow breastfeeding in that postpartum period. In fact, it's encouraged because of the all of the other good things that come with breastfeeding that Hep B infected mothers do breastfeed. The only exceptions and reasons to not breastfeed is if you have overt blood in your breast milk or very severe mastitis with bleeding around the nipple because of the blood chance for blood exposure there. So mothers on treatment can choose not to breastfeed, as medication can be secreted in very small doses in milk. And Hep B infected pregnant women who are not on antiviral therapy, as well as those who stop antiviral therapy at or early after delivery, should be monitored closely for up to 6 months in that postpartum period to look for flares. Long-term follow-up should also be continued to be assessed for determining the needs of future long-term antiviral therapy. All right, so let's talk a little bit about preventing perinatal Hep B transmission at delivery, because I think this is really an important point, and it's something that in the various different practices that you're involved with, these are important things to have a good understanding about. So we recommend screening all pregnant women for Hep B with at least testing for Hep B surface antigen. This algorithm kind of takes us through what to do if the surface antigen test result is available prior to delivery. So in a surface antigen positive woman who's pregnant, it's important to kind of follow the measures here in purple. So make sure that that is documented as part of the electronic health record or delivery chart for both the mom and baby. The pediatricians are usually alerted by the OB doctors in order for the nursery to make sure that hepatitis B vaccine and Hep B immunoglobulin can be administered, again, within 12 hours of birth. It's not before discharge from the hospital. Optimal prophylaxis happens within the first 12 hours to improve the best chances for reducing mother to child transmission risk. And then it's important that the vaccine and immunoglobulin are administered in separate limbs within 12 hours or as soon as possible. And again, the pediatric provider is typically very involved. This is reportable to public health departments, which then also compile data and share with the CDC and other national organizations for public health awareness and knowledge of where things are at. And again, to report results in the immunization registry. And then in surface antigen negative women, it's important to assess risk factors and if those risk factors might influence whether or not you're in a potential period of recent exposure where your surface antigen may not come back the initial time you tested as positive, and then you can consider if there is risk factor present to retest surface antigen at the time of delivery. And then that again would take you down, the various pathways depending on whether or not you're negative or positive. So again, this is a nice little resource that's been put together by the CDC. And for those who do get vaccinated within 12 hours, it's important to make sure that they follow through and complete the full vaccine series. There are 3 in that. And most public health agencies now have a perinatal hepatitis B coordinator who's involved in this follow-up. And this is a program that's been funded by the CDC and hopefully will continue. All right, and then what do we do if the surface antigen test is not available to you at the time of delivery? And this is, a scenario that does happen in real life. It's not the optimal scenario we hope to have. We hope to have pregnant women engaged in healthcare ahead of time so that we can screen them appropriately and know the status. But this is an algorithm that the CDC has put together in case those results are not available at the time of an infant's birth, and kind of takes you through prophylactically administering vaccine and Hep B immunoglobulin based on the baby's weight versus only giving the vaccine. And then once the test results are available, you kind of follow down the surface antigen versus the surface antigen positive and negative pathways depending on the status. So these are, again, available on the link below for you to refer back to, but handy things to kind of share with providers in your network. All right, so there is a suggested algorithm for management of hepatitis B in pregnancy that kind of takes into account what AASLD and others have put forth. And again, initiation of antivirals is recommended with tenofovir weeks, some say 28 to 32, but 30 to 32 at least if the Hep B viral load is greater than 200,000 IUs per ml. And then it's important, the recommendations by AASLD and others is to discontinue antivirals at the time of delivery or within the 1 month postpartum period because of the lack of benefits with preventing flares with more long-term treatment. So we typically will stop the antiviral treatment at delivery or within 1 month postpartum because of lack of data to say that there's any benefit with extending therapy. But then it's important to monitor the moms with the ALT every 3 months for the first 6 months after delivery. And I would add DNA levels are usually also checked as part of this. And then if a patient is already taking tenofovir, great. You just continue the tenofovir throughout pregnancy if there's no detectable Hep B DNA. And if they're taking other, antiviral therapy, including telbuvir or LAM, the Hep B DNA helps you determine whether or not to switch to tenofovir during pregnancy. And if their Hep B is not detectable on telbuvir or LAM, then you just continue them on those agents through. All right, so that kind of went over, a lot of information with respect to women who are pregnant and what to do with women who are infected with Hep B in pregnancy, how to manage the mom optimally to reduce the risk of mother-to-child transmission, so antiviral therapy for those who meet the criteria, and then immunoprophylaxis for the babies within 12 hours of birth. So shifting gears from pregnancy and Hep B, Another common scenario that you're going to come across is this concept of Hep B reactivation. And Hep B reactivation is defined as a clinical syndrome characterized by a sudden increase in Hep B replication due to a loss in immune control. So this can occur in kind of really two groups of patients. One is in people who are clearly infected with chronic hepatitis B, who are surface antigen positive, but it's also something that can be seen, and this is a really important thing to keep in mind, in people who are surface antigen negative, so they don't have infection with Hep B, but people who are core antibody positive, irrespective of their surface antibody status. So remember, the core antibody is, as we talked about in our lecture series 2 and 3 out of this 5-part series, when we talked about serologies, that core antibody positive is just really a marker for prior exposure and or infection. So anybody who is core antibody positive is also unfortunately at risk for Hep B reactivation in the setting of loss of immune control. Now, a Hep B reactivation can present clinically in a kind of really wide range. It can be silent and picked up based on kind of blood work monitoring, and it can unfortunately also be manifested as overt acute liver failure, which is the scenario obviously we're always trying to avoid, but unfortunately happens too often. I'd say at the institution where I practice, we have one case of acute liver failure, typically resulting in death, unfortunately, because somebody either was not screened or prophylaxed in the setting of immunosuppression. So this takes us kind of to the next point, that really this loss of immune control is mostly seen in the setting with immunosuppressive drugs. So drugs that we're giving to patients. And so it's really our obligation as providers to be aware of this problem and also to appropriately be able to either refer them to be screened and managed and monitored to prevent bad outcomes. Now, one of the things we struggle with when we talk about Hep B reactivation is a lack of standardized criteria. And so I'm going to give you what the AASLD has put forward. Again, the AASLD is the American Association for the Study of Liver Diseases. It's our national professional organization that puts out guidelines, recommendations for Hep B and other liver diseases. And then I'm also going to talk about some generally accepted criteria, because this is what a lot of different studies have used historically. Again, there's no universal, widely accepted across the board. These are the set criteria, but just to give you a sense, it includes some definition of a rise in Hep B DNA from baseline. So this is not very clearly set as a 1 log increase or a certain amount. Generally accepted criteria include either a 1 or 2 log increase in that Hep B DNA viral load, and you can also see what we call reverse seroconversion or seroreversion. So just try not to get lost in the terminology here, where you can go from surface antigen negative to surface antigen positive. So that is a definition of reactivation. Or if, and this is for people who are surface antigen negative, but are core antibody positive. So again, you can go from really a core antibody positive patient who's surface antigen negative, and in this setting of reactivation, the surface antigen becomes positive. And then you can also see a kind of liver enzyme increase, and we look at the ALT elevation for that. And then again, kind of some ways to help define this in some of the studies, greater than or equal to a 2-fold increase above baseline for your ALT. AST elevations are not always present. And that kind of goes over what some of the criteria you'll see in guidelines and studies. So there are a number of factors that put us at risk for Hep B reactivation, and these can be related to largely the groups of host, viral, or drugs. Men, younger age individuals, and having an elevated ALT before the initiation of immunosuppression, and other underlying comorbid conditions can be host-related variables that put you at increased risk for reactivation. There are viral related factors as well. So in somebody who's surface antigen positive, having a higher Hep B DNA load, somebody who's E antigen positive, surface antigen positive patients are higher risk than surface antigen negative patients who are core antibody positive. There are some other variables that we don't always use in clinical practice very widely, but have been studied, including having mutations in the pre-core mutant or the core promoter mutant and lower Hep B surface antibody titers. And then finally, the category I think for us to be most aware of, in addition to these host and viral factors, include which drugs you're selecting with respect to immunosuppression. So the intensity of the drug and the duration of immunosuppression put people at higher risk depending on what those medications are. Rituximab is one to just always, always, always remember as putting patients at a highest category of risk for Hep B reactivation. And rituximab is now used in a lot of different clinical scenarios. And other agents, including high-dose steroids, anthracycline, and stem cell transplantation also can present risk variables. So what do I mean by the degree of immunosuppression? Well, this is really based on the therapy that we're giving to a patient for whatever condition that they may require immunomodulation or immunosuppression. And I will say, you know, we've had a rapid rise of use of some of these immunosuppression categories of agents for, again, a wide variety of rheumatological, immune-related bowel diseases, and other conditions. So our awareness of this needs to become heightened as we are seeing these agents being used more commonly for a variety of conditions. And then again, rituximab is probably one of the ones that you're going to think about the most in terms of putting somebody at high risk. The highest risk categories are, you know, people who are undergoing stem cell transplant and solid organ transplant. So all of those patients routinely are screened pretty aggressively for their Hep B status. So the AASLD has put together screening recommendations, and it's really recommended all patients, all candidates for immunosuppressive, cytotoxic, or immunomodulatory therapy get tested for hepatitis B surface antigen and core antibody. And remember, certainly it's good practice in screening to also do the surface antibody, but the recommendations and risk really depend on the surface antigen and the core antibody test results. So really independent of the surface antibody result, the two things you need to know the status on in this setting is surface antigen and core antibody. Remember, the presence of surface antibody does not prevent reactivation, okay? So, and that is particularly true in the surface antigen negative person who's core antibody positive. We do know that surface antigen positive patients are certainly at higher risk for reactivation, so 41 to 53% in surface antigen positive patients receiving anti-cancer therapies, and it's lower in surface antigen negative patients receiving anti-cancer therapies who are core antibody positive. So reactivation occurs in the range of 8 to 18%. And then just keep in mind, because we are using a lot more immunosuppressive immunomodulatory therapies in the context of anti-rheumatic therapies, and the risk is much higher for surface antigen or chronically infected patients at 12.3% versus 1.7% in those who are just core antibody positive. I think one of the big take homes here is that we're still not doing enough in terms of testing patients who are even undergoing cancer therapy, let alone some of these other indications for immunomodulatory immunosuppressive therapies. So even in cancer patients who are receiving cancer therapy, it's, you know, more than half that we're not testing or screening appropriately ahead of time. The AASLD has recommended that all surface antigen and core antibody patients should initiate antiviral therapy for hepatitis B before immunosuppressive or cytotoxic therapy. So it's recommended that we administer before or at the latest, because sometimes we're getting a consultation in the hospital that we want to start therapy for this really aggressive, you know, cancer-related disorder, and we don't want to delay cancer therapy. So we can start Hep B therapy simultaneously to immunosuppressive therapies, and that's an okay strategy. Ideally to do it before, but sometimes we don't have that option in some clinical settings. And then it's really important to continue antiviral therapy, not only during the immunosuppressive therapy, but for up to, you know, greater than 6 months after you stop immunosuppressive therapy. And the one caveat to that is anybody receiving anti-CD20 therapies, they get actually prophylaxed for longer at a minimum of 12 months. I actually just saw a patient last year who discontinued prophylactic therapy early after receiving anti-CD20 therapies. He was an Asian patient who was Hep B core antigen positive, but surface antigen negative. And he came in with fulminant hepatic failure, and he was way too sick actually to survive. So this is a real thing with bad outcomes. So it's really important for us to have a heightened awareness about it. And again, the recommended antivirals we can offer patients in this setting include entecavir, tenofovir, and TAF. And these are the agents, remember, that have higher potency and higher resistance barriers. So these are really considered first-line therapies. In surface antigen negative patients who are core antibody positive, patients should be carefully monitored with their ALT, Hep B DNA, and surface antigen. And these are for people not undergoing stem cell transplant, solid organ transplant, or some of the higher risk category drugs. But some of the lower risk category drugs, we can kind of do this intent or on-demand therapy where we monitor the ALT and Hep B DNA very closely, typically, monthly at least, sometimes more often, to see if we catch the rise in the DNA or the ALT, and then initiate antiviral therapy. Again, one of the exceptions to this, anybody receiving rituximab, that should scream out, initiate antiviral prophylaxis in all of those patients, and similarly, people undergoing stem cell or solid organ transplant. And for patients being monitored, again, without prophylaxis, as I just mentioned, Hep B DNA levels should be obtained at least every 1 to 3 months. Patients should be monitored for up to 12 months after they discontinue anti-Hep B therapy in any scenario. All right, and so we've talked about, pregnant women, risk of Hep B and or actual Hep B infection, Hep B reactivation, which we most commonly see in the setting of immunosuppressive therapies that we administer to patients. And I wanted to include at least one brief slide on what to do in the setting of Delta infection. So Delta infection this is actually a hepatitis Delta virus. It's a defective RNA virus that actually requires Hep B virus to be present to replicate. And so you'll never see this isolated. It'll only be present in the setting of somebody who's also got Hep B infection. The incubation period is anywhere from 5 to 64 days. And there are really kind of two clinical scenarios in which you see infection present. One is a superinfection, where somebody's already infected with chronic Hep B, and then they develop acute Delta virus because of the risk factors, which are listed here, which include parenteral, injection drug use, and sexual. And I will say, because of the rise of the opioid epidemic, and we've seen a dramatic increase in the number of actually Hep B infections in young persons because of injection drug use and parenteral transmission, we're seeing actually more Delta infection as well. And this superinfection clinical scenario where you have chronic Hep B and then you develop acute Delta virus infection is really a worse prognosis. You get a more severe liver disease in a shorter amount of time, because again, you have two viruses negatively impacting what's going on in the liver. So rather than taking, maybe up to 40 years to develop cirrhosis, you can develop cirrhosis at a much younger age. And 80% of these people in this scenario, because the chronic Hep B virus is present, and at that stage, once it's chronic, we don't expect people to lose it on their own or the immune system to kick it out. Delta infection also becomes a chronic infection for these patients. So you have two viral hepatitis infections working against liver fibrosis and function. The other clinical scenario is co-infection. This is where you acquire both hepatitis B and Delta at the same time. And again, the kind of, the board review kind of question scenario here is somebody who's like an injection drug user who gets very sick and presents, with kind of a self-limiting hepatitis, because again, most commonly you're having these risk factors as adults, and adults who acquire Hep B infection are much higher likelihood of kicking it out of their system and curing themselves and not having chronic infection. And so once Hep B gets kicked out of the system, Delta virus is again a defective RNA virus. So if the Hep B is not present, it cannot go on to develop chronic infection. This is typically a self-limiting hepatitis that might present with a biphasic ALT. That's the kind of board hallmark. And less than 5% of these people go on to develop chronic infection. You can do diagnosis with Delta antibody. And if that's positive, we typically will, in the right scenario, if you think there's been recent risk factors, send off an IgM and an RNA. And these are tests that are run through the CDC. And there's a process you can go through their website, print out their form, send a tube of blood to them, and they run these tests for us. And then sometimes a liver biopsy could be considered to stain, but again, we do biopsies much less commonly these days, given our non-invasive fibrosis tests we have available. The clinical presentation, again, can be wide-ranging from self-limiting to more severe chronic hepatitis at a younger age, and sometimes also fulminant hepatic failure. And the treatment, the only approved treatment for Delta infection is actually pegylated interferon, and that's administered for 12 to 18 months.